Good afternoon, gentlemen. It's our time to start the afternoon session. We're focusing on that, I think it's HOCM or some obstructive. We welcome many participants since we have a world expert of this. Dr. Schaff is going to start the lecture. Oh, thank you, sir.
Thank you. In the postgraduate session, we talked about the techniques of septal myectomy, and we were going to defer any discussion of outcomes until today. So I wanted to review outcomes of septal myectomy, at least from our experience. No disclosures. Acknowledge that much of the information that I'll share with you is a result of our clinical research programs supported by the Tsai family. Now, this is an ambitious list of topics to cover as regards outcome. If I get close to the end and I've not completed it, I will stop on time. But I wanted to talk about outcomes of septal myectomy for obstructive hypertrophic cardiomyopathy in relationship to medical therapy. I want to talk about latent versus resting obstruction, management of mitral regurgitation, septal thickness, comparison to alcohol ablation, and results of enlargement for a non-obstructive disease. Now, medical therapy, if you look at the guidelines, the indication for surgery is to relieve symptoms when symptoms persist despite medical treatment. There is, however, no evidence that medical treatment does anything other than relieve symptoms. There's no data to support the routine use of medicines to improve survival or prevent progression of disease. That may change with this new drug, mavacamten. It's a small molecule inhibitor of myocardial myosin contraction, and it does reduce hypercontractility, so that's something to keep an eye on. Patients are symptomatic because of usually with shortness of breath or chest pain related to mitral regurgitation, increased end-diastolic pressure. But the other thing that happens with patients who have obstructive HCM is you actually have a reduction in stroke volume when you are obstructed. And if you look at this slide, look at the left-hand panel. The blue is at rest. That's a gradient. That's the gradient at rest and with exercise or with provocation and aortic flow. With aortic stenosis, if you give a PVC to the heart, you get augmentation of a gradient and augmentation of a flow. In a patient with hypertrophic obstructive cardiomyopathy, if you provoke a PVC, you get an increase in a gradient and actually a decrease in stroke volume. After surgery, with both aortic stenosis and hypertrophic cardiomyopathy, you get an increase in stroke volume when you relieve obstruction. And that's why patients feel so miserable when they exercise with hypertrophic cardiomyopathy. Now, there's two very important studies that Barry Marin did that address the issue of obstruction and whether that relates to survival. And the first one was published almost 20 years ago, 15 years ago. And he looked at the outcome of patients with obstruction and without obstruction. And it used to be said that obstruction produced symptoms but didn't have any influence on survival. But as you can see here, there's a clear difference in survival of patients with obstruction and patients without. That was independent of all the usual suspects, the degree of disability, the presence of atrial fibrillation, and wall thickness. Now, Steve Amman, who's a cardiologist from our group, compared the outcome of patients at Mayo Clinic who had had septal myectomy, shown in the dark blue on the top line, with patients from Marin's study. And the patients that have had a septal myectomy behave more like non-obstructed cases, as you might expect. So whatever mortality penalty there was for obstruction is relieved with an adequate myectomy. Now, one of the reasons is that there's maybe a decrease in arrhythmic deaths. If you look at appropriate ICD discharges in patients that have had myectomy, it's very low compared to unoperated patients with obstructive hypertrophic cardiomyopathy shown in blue. Now, this is the bottom line from our institution with follow-up up to 25 years. Shown in blue are men and women. The dotted line is the expected survival. The red dotted line is expected survival for women. So up until about 15 years, the survival of men and women is the same, but beyond 15 years, men seem to have a little bit better survival, and they stay very close to expected survival, whereas women's survival, for some reason, after 15 years is not as good. We don't see any difference in late survival according to genetic status. So gene-positive patients have the same survival as patients who are gene-negative. The second important study that Barry Marin, I think, is fundamental to surgeons that Barry Marin did, and that's to highlight the importance of latent obstruction. So in his clinic, when he looked at 320 symptomatic patients with HCM, about a third of the patients had resting obstruction, about a third of the patients had what we call latent obstruction, and a third of the patients had no outflow tract obstruction. In the past, we used to think that outflow tract obstruction was present in a minority of patients, and now it looks like it's present, at least in symptomatic patients, in the majority. Now here's a typical patient who has obstructive hypertrophic cardiomyopathy, has been put to sleep for a myectomy, and you can see that the outflow tract is wide open. There's very little mitral regurgitation and no flow acceleration. So does this patient have hypertrophic cardiomyopathy? Well, the answer is yes. Because if you give this patient isoprel, and this is before surgery, you see massive mitral regurgitation and you see systolic anterior motion of the mitral valve. So this is a typical patient with latent outflow tract obstruction. And this is what it looks like after septal myectomy. You can see the myectomy site, and this is with isoprel provocation. There's just a trace or mild residual mitral regurgitation, but no systolic anterior motion. Now, patients that have latent obstruction have a myectomy have exactly the same result as patients who have resting obstruction in terms of survival and also in terms of symptomatic improvement. This is a percentage of patients who are class 1 or 2. It doesn't matter whether you have latent obstruction or fixed obstruction. We talked some before about management of mitral regurgitation. In our practice, if you don't have intrinsic mitral valve disease, the chance of needing something done to the mitral valve is about 2%. On the other hand, if you have, and you get rid of most of the mitral regurgitation by doing an adequate myectomy. On the other hand, if you have intrinsic mitral valve disease, in our experience, your survival is better with a myectomy and a mitral valve repair than it is with a myectomy and a mitral valve replacement. So even though mitral valve replacement has been advocated by some to completely relieve the gradient and get rid of the mitral regurgitation, we think you should do everything possible to repair the valve and do an adequate myectomy. Now, what about septal thickness? It used to be said that if you had a septal thickness of less than 18, you probably shouldn't have a myectomy because of the risks of VSD. About 20% of our patients have septal thicknesses less than 20. Here's a patient with a 12 millimeter septal thickness preoperatively, and you can see postoperatively there's no more SAM, and the septal thickness is 8 millimeters. Now, it really doesn't matter whether you have a thinner septum or an intermediate sized septum or a very large septum, the reduction in the resting gradient with myectomy is the same. Likewise, the risk of VSD and the mortality is the same for patients with septal thicknesses less than 18, 18 to 21, and greater than 21. The survival of patients with different septal thicknesses is the same. And this is interesting because we would have projected that it had nothing to do with gradient, but you might have increased late mortality in patients with very thick ventricles, but we don't see that in this group of patients. Now, what about comparison to alcohol septal ablation? This is a patient who's had an alcohol septal ablation. You can see the large scar there early after alcohol ablation. And what happens afterwards is shown here. You get quite a large scar in the septum, where a patient after a myectomy just has a thinned out septum with no scar. The concern that people had with alcohol septal ablation is VT. And even though that's not shown up in every study of alcohol septal ablation, there are plenty of case reports of patients that have sustained ventricular tachycardia after ablation. We've compared patients who had alcohol septal ablation to patients that had surgery. Survival of patients with surgery was better, but in our practice, our cardiologists only do, or not only do, but mainly do alcohol septal ablation in patients that are at higher risk. So once you go through propensity matching and get patients that are relatively comparable, that difference in survival is reduced. On the other hand, patients that have septal myectomy have a survival that's as good or better than expected, where patients with alcohol septal ablation, the survival is a little bit worse. Now, I won't say too much more about this because I know Aubrey Almeida is going to talk in more depth about outcome of alcohol septal ablation. Reintervention rate is much less with surgery. It really doesn't matter what pre-intervention pressure gradient you have, you get the same result after surgery, whereas with alcohol septal ablation, the higher the gradient before, the higher the gradient afterwards. In our experience, you have better functional outcome with myectomy. Now, I'll finish with a discussion of the outcome of apical myectomy, because this is a newer procedure. This is a typical patient. This is a 22-year-old young man who was referred to us who was quite limited. In fact, he played in a rock band but couldn't participate in a band. He was sedentary. These patients are difficult to manage medically. He was unresponsive to beta blockers and had been referred for transplant. And he wanted something other than a heart transplant. This is what his mother wrote to us. She said, "We believe if Justin's quality of life improves to the point where he can regain some mobility and spend a few hours of the day out of bed, the surgery can be counted as a success." I think you'll agree with me that that's a pretty low bar for success that we had. And here is his ventricle before myectomy. And you can appreciate the reason that he couldn't get out of bed or do much activity. His left ventricular cavity is very small and his stroke volume is very small. In the past, all we had to offer these patients was transplant. Now here is his echocardiogram after apical myectomy. Not a perfect ventricle, but I think you can see that there is a chamber and there is ejection from that chamber. In fact, his stroke volume, when it was calculated by the cardiologist after surgery, was 72, which is near normal. Here's Justin a year after surgery playing in his rock band, and so we met the low bar for success here. Now, through March of 2017, we'd done the operation over 100 patients. We probably now have 150 patients, and the results are about the same. Generally, the patients are younger, but almost all of them were very symptomatic, class 3 or 4 limitation. And here's the results. These are the 15-year results of apical myectomy at our institution. Not as good a survival as patients that have subaortic obstruction, but still a reasonable survival. But the issue is, would these patients have been better off with transplant? So we were able to compare patients who had the procedure, apical myectomy in blue, with patients from one of our national databases that looked at the survival of patients on the transplant waiting list with the diagnosis of hypertrophic cardiomyopathy. And at least in an unadjusted survival, we didn't have all the variables to adjust for, the survival was better in patients who had the myectomy rather than going on the transplant wait list. When you adjust, actually the curves don't narrow, they get a little further apart, so the survival of the patients with myectomy even looks a little better in relationship to patients listed for transplant. Now, what about patients who end up getting a transplant? The patients that had apical myectomy survive just as well as a patient who actually receives a heart. And it doesn't matter whether it's unadjusted survival or adjusted survival. So I'll finish. I think the key points, at least through the latter part of the presentation, is the apical phenotype is not always benign. When the patients develop symptoms, they're very difficult to manage medically. The apical myectomy is, I think, a good option for selected patients with diastolic heart failure and reduced volume. The general guidelines are in diastolic volume less than 50 mLs per meter squared and a stroke volume of less than 30 mLs per meter squared. We've documented, I think, that the operation improves diastolic function. We talked about that some earlier, and it increases end diastolic volume, increases the stroke volume, and decreases end diastolic pressure, and symptoms improve in most patients. The survival of the patients after apical myectomy is superior to that of patients listed for heart transplant, so we think it's quite a good option for them. I wanted to take a minute too and end by recognizing that most of these longitudinal studies are done by our HCM research group, who are shown here, and I appreciate all the good work that they've done. Thank you.
Questions?
That was a very good presentation. Actually, I came in late, so I may have missed it. How do the results differ if there is a right ventricular type of HOCM?
Now, there are patients, generally these are younger patients, children, who have some degree of right ventricular outflow tract obstruction. If we find that in the gradients more than 30 or so, we would open the right ventricle and do a myectomy on the right side as well.
So it's to the right ventricle, right?
For the right ventricle, right.
I was seeing a presentation yesterday in one of the pediatric sessions where the apical ventriculotomy was done through the mitral valve. And what is your take on this?
Yeah, doing a myectomy through a mitral valve is possible. We generally reserve that operation for children or someone with a very small aorta where our visualization of the septum is poor. I've also done that in a patient that had a mitral prosthesis, an aortic prosthesis in place, a mechanical valve, but the exposure was not good that way. It's an option if you want to use it, but I suspect that if you do enough cases, you're going to find someone where you get a problem with mitral regurgitation by reattaching the anterior leaflet. We think that a transaortic myectomy is a better option.
Yeah, I remember hearing Joe Dirani talking once about the exposure to the apex, and he showed that you use some kind of fiber optic light to visualize the apex.
I'm sorry, who what?
I remember seeing a presentation by Joe Dirani in which he said that you get a good exposure if you fiber optic source through the aortic valve to see the left ventricular apex. So what is your take on that?
Well, if the patient has SAM, we will always do a transaortic myectomy. If a patient has SAM and midventricular obstruction, then we would do a transaortic myectomy and then a transapical myectomy to get to the midventricle. So if it's midventricular obstruction, we prefer to go through the apex of the heart for those patients.
And how about doing a pre-op of the septum?
A pre-op what?
MRI, magnetic resonance imaging.
Well, many patients get a pre-op MRI at our institution, but it rarely guides the surgery. It's more helpful for looking for late gadolinium enhancement and trying to make an assessment about whether a patient needs an ICD. Most of the time, we can make a determination about the need for operation for obstructive HCM with an echo. Now, for a patient who has diastolic heart failure and no obstruction, and we're trying to do one of these operations that I just showed you, the transapical, we do get the MRI for those.
Thank you so much.
Excuse me. This is Vivek Zabli from Bangalore on your side. While doing an apical myectomy, any technical tips that you would like to highlight?
Yeah, well, yes, I think there's two. First of all, position the apical ventriculotomy far enough from the LAD that you don't compromise that during closure. And then secondly, most of the muscle that we take, even though that is not reflected very accurately on the images that I showed earlier, most of the muscle we take is from the septum. And the main hazard for a surgeon, and I've made that mistake, is injury to the papillary muscle. So the first thing I do once I identify the LV cavity through the apex is to put the cardiotomy sucker through the incision and have my assistant pull the papillary muscle away from me towards him or her, and then I do the septal myectomy without worrying about injuring the papillary muscle.
Thank you.
Thank you, Dr. Schaff. I think you've
Okay.
here. All of us know about a regular myectomy. My doubt about an apical myectomy, which we've not seen at all, is do you always go by a combined approach of through the aortic valve and the left ventricular aortotomy or right?
No,
ventriculotomy?
Yeah. We use a transapical incision in 3 situations.
Yeah.
One is if there's combined obstruction. In other words, you have subaortic obstruction with SAM and you have midventricular. So in that case, we'd do a transaortic and a transapical. The second situation is isolated midventricular obstruction. If I see a patient with no SAM but isolated midventricular obstruction, I'd go through the apex. And then the third reason to go through the apex is to enlarge the ventricle in patients with non-obstructive hypertrophic cardiomyopathy.
And does your echo or the MRI guide you of how much you're going to resect, or you look at the residual cavity at the end of the resect?
Very common question, and I'm going to answer yes, but it's not the depth of the myectomy, it's the extent towards the apex. So yes, the echo helps us, it guides us. We do in fact, there are many times that we will do, if somebody has mitral regurgitation and the echocardiographer says, boy, I don't think this is SAM related, but I don't see any prolapse, then what you need to do there is do an adequate myectomy and then come off bypass and see if it goes away. And so echo helps in that, guide us there.
Sometimes this HOCM patient have some degree of ventricular fibrillation or BT. So ICD first or this myectomy first? Which one you should prefer?
It's a question that comes up commonly. What do we do? If a patient is at risk for ventricular tachycardia or ventricular arrhythmias, the decision to put in a defibrillator is made before the operation, and the cardiologist put them in on about the 3rd postoperative day. So we don't do it intraoperatively, we do it on the 3rd day, and we would do it even if we do a great myectomy. Now, it's very interesting because if you look at the guidelines in the US guidelines don't include obstruction as a risk factor for sudden cardiac death. The European guidelines do include obstruction as a risk factor for sudden cardiac death. It's the only risk factor that you can modify. I don't know why the US guidelines don't include it because it's, I think there's evidence that I just showed you that there's improved survival with surgery and there's reduced arrhythmic events, but somehow that didn't make it into the guidelines.
Another question about the mitral regurgitation. You say sometimes it is latent. So you run the heart with the isopreneurin and see how much the mitral regurgitation is there. So when do you decide to repair the mitral valve?
Yes, we would repair the mitral valve if there's ruptured cords. We have probably 75 or 100 patients that actually have ruptured cords and hypertrophic cardiomyopathy with obstruction. Those patients are really sick because to treat mitral regurgitation, you unload the ventricle. If you unload the ventricle with hypertrophic cardiomyopathy, you worsen the outflow tract obstruction. So the patients that we're doing the mitral repairs on are patients with intrinsic mitral valve disease and leaflet prolapse.
Thank you very much.
All right, thank you.
Dr. Shah, just so you know, I've got a little bit of an impromptu case discussion that I'm going to ask you to be involved in. So.
Thank you, Dr. Schaff. The next lecture will be by Dr. Almeida.
No sound. No, that's fine. Thank you. So again, thank you for the opportunity to speak today. My disclosures are that I am most definitely not an expert on treating hypertrophic cardiomyopathy either by alcohol septal ablation or via septal myectomy. I am involved in a program where we do discuss every patient who is going to be treated and we have a good relationship with the cardiologists. And my second disclosure is that everything I know about treating HOCM, obstructive HOCM, is things I've learned from my time at Mayo Clinic and Dr. Schaff, Dr. Delaney, and Dr. Danielson. Just to reiterate, one of the very important things about being a surgeon involved in any of these programs is that you need to understand the disease process and the options for treatment as well as the cardiologists do. If you go into that discussion and you don't understand any of these issues, there is no way that you can be an appropriate advocate for your patient. So again, just to reiterate this point, and I've been busy deleting slides as Dr. Schaff was giving his talk, but I think this is really important. Septal reduction therapy of whatever sort is indicated for severe symptoms despite optimal medical therapy. And you need to have a significant gradient which is either arresting or provocable. And you know, it's really important that we make sure that this is clear. Having said that, once somebody has symptoms despite optimal medical therapy, and they have these provocable gradients, they should be treated. And the longer you leave these patients, the more trouble they get into. There have been a few papers over time looking at alcohol septal ablation versus septal myectomy. It's worthwhile having a look at some of these papers. Now, it's interesting, a lot of the papers are actually written by cardiologists who work at Mayo Clinic. And I'll be a little bit controversial here. I suspect in some ways they've been a little bit generous because of the excellence of the surgery at Mayo Clinic. And it may well be that, in fact, some of the reason why alcohol septal ablation has done so well is because we as surgeons have not done as good a job as we should. Now, this is a list of the advantages and disadvantages of surgical myectomy. I won't go through all these details, but basically it works and it's able to treat a wide spectrum of disease. The authors, cardiologists, have been quite generous and they've only listed 2 disadvantages. That is, open heart surgery requires cardiopulmonary bypass and sternotomy, a prolonged recovery, and it needs somebody who's competent at doing it. Again, quite a long list. You can treat the mitral valve, you can treat the extended part of the septum, you can treat other disease processes happening at the same time. There's no scar, etc., etc., etc. Having said that, I do think that we as surgeons need to be reasonably open and understanding of what are some of the limitations of what we do in order that we actually do it better. And to say, oh, well, alcohol septal ablation is hopeless, surgery is fantastic, there's no issues, means that you go into the procedure without an adequate understanding and you won't do as good a job. There is most definitely a risk of ventricular septal defect, injury to the aortic valve, injury to the mitral valve, incomplete resection, which is very common in surgeons who aren't doing this frequently. We can certainly cause left bundle branch block or complete heart block, as we've seen. Some of these patients are really very sick and they have a significant component of diastolic heart failure. And if we don't understand the disease process and either intervene inappropriately for the wrong indication or we do the wrong operation that's indicated, these patients can die after heart surgery because of cardiogenic shock. And again, it is very operator dependent. One of the other things that we must do as surgeons if we're involved in this sort of program is understand what the opposition are going to be doing, if we want to consider them opposition, or what our colleagues are going to be offering. And it's really important to go to the lab, see a number of these cases, read around it, understand. And I think perhaps the most valuable thing I can offer you today is a bit of an understanding in how alcohol septal ablation works. So basically what we're doing is the cardiologist will find the appropriate vessel that feeds an area that they believe is contributing to the problem, and they'll inject alcohol. And so basically this started in the mid-90s, around 94, the first cases were done in the UK, and they inject somewhere between 1 and 4 mils of 96% ethanol in a septal perforator. And I'll just go through a bit of a case that was done at our institution. So here you can see a patient. In fact, they don't seem to have a heck of a lot of SAM here. They do definitely have a provocable gradient. You can see again the outflow tract, a bit of turbulence, not a lot of mitral regurgitation. Then we do a coronary angiogram. We find what we think is the most appropriate vessel. And normally this is a subsegmental sub-branch that we find. Go down there with a guide wire. Once we've done that, then put in a balloon. And the first step of this with the balloon, and a couple of little tricks here, is they can't blow the balloon up too high, otherwise it squashes the cannula that's inside the balloon, so they can't do a high pressure inflation, which is one of the risks. That's why alcohol sometimes gets out. and they inject a echo contrast. And that echo contrast lights up, and the important part of this is if the echo contrast is not going into the right area, then the procedure should stop, look for another vessel, etc., etc. So it really needs to be done by people with experience and understanding. Once you've done that, then the alcohol is injected, and then this angiogram shows that sub-branch that was cannulated, it no longer has flow in it. And then you do the follow-up study. Quite often, in fact, they won't get rid of the gradient completely at the time of the procedure. There is a bit of stunning that happens, and not infrequently the SAM will go away, but really what they're looking at is a long-term result. And you can see in this case, a really excellent, quite extensive myomectomy or scar in that area. And it can be quite effective. But what are the limitations of it? Certainly, it's very much dictated to by the anatomy. It's limited by the septal size, the septal distribution, the coronary collaterals. So any collateralization will allow the alcohol to either get washed out or to escape, and can either limit the size of the scar or in fact make the scar much larger and cause significant troubles. In the other issue obviously is what part of the ventricle, what part of the septum is contributing to the LV outflow tract obstruction, and does that correlate with the septals? Other limitations, the septal hypertrophy varies enormously, and there are difficulties with this. As you saw from Dr. Schaff's talk, the size of the septum does not matter in a surgical septal myectomy, but it does matter in an alcohol septal ablation. Any anomalies of the mitral valve apparatus, including accessory papillary muscles, accessory cords, really aren't addressed by this problem. And as alluded to, the risk of scar-mediated arrhythmia varies somewhere between 5 and 8%, depending on the study. And certainly there is significant concern about that, especially in younger patients. The alcohol may not be confined to the basal septum, and we had one patient at our institution who died after an extensive septal infarct following alcohol septal ablation. Consistently throughout the literature, there is a 10 to 15% incidence of complete heart block and permanent pacemaker. Now that may not sound too bad, but in patients who've got significant diastolic impairment, that can be a real problem. And right bundle branch block, as opposed to left bundle, is quite common after an alcohol septal ablation. There has been studies looking at ICD shocks following alcohol septal ablation, and the incidence is around 8 times higher than surgical myectomy. There have been a couple of reviews, and it's worthwhile having a look at. I personally, to be honest with you, don't like meta-analyses, but we have a little bit of a limitation here because there are no randomized control studies. So this study looked at all the literature that's out there, found basically 22 appropriate longer-term follow-ups, so 6 years in each group, 22 in the alcohol septal group, 23 in the septal myectomy group, and around 4,200 patients in each. Basically, this study showed that septal myectomy carried a higher mortality, 2% versus 2.2%, a higher stroke rate, 1.5 versus 0.8%, but definitely a much higher pacemaker rate in the alcohol septal ablation group, and a much higher incidence of re-intervention in that group. Interestingly though, in the longer term, the incidence of all-cause mortality was no different over the 6-year time frame. And essentially, if you look at all-cause mortality, cardiac-specific mortality, really there was no incidence, and this is the scatter plots to show you. This is, I think, a very valuable paper. Dr. Schaff didn't talk in a lot of detail about this, and I'm glad because I did want to discuss some of this with you. This is a study out of Mayo Clinic. Again, about 2,400 patients having septal myectomy, about 200 having alcohol septal ablation, 2-to-1 propensity score matching, and so they came up with 330 patients having myectomy, 160 having septal ablation. The patients had a much better resting LV outflow tract resolution of gradient following the surgical myectomy, which, after what I've said about alcohol septal ablation, is probably no real surprise. They found no survival difference between the two groups, but Again, I'd be interested to ask Dr. Schaff about this because the hazard ratio was 1.5 and perhaps with bigger patient population, it may have reached statistical significance. What is interesting though is the myectomy population in this study had a better survival at 12 years than the matched US population, whereas the alcohol septal ablation group did not. And the rate of reintervention for the alcohol septal ablation was sickeningly higher than the surgical myectomy group with a hazard ratio of 33.3. In the last couple of minutes, I just want to talk about a couple of issues, I guess. This is a paper from Barry Marin and Rick Nishimura, and basically their take on it is that because of the excellent results at Mayo Clinic, that surgery is probably the way to go. And that's been echoed in a number of other papers. Again, this one from Barry says surgery is the gold standard and the best results are in high volume centres. What does that actually mean though? So there is this study which came out in 2016, JAMA Cardiology. They looked at the USA 2003 to 2011. They found 11,000 patients, 57% of them had myectomy, 43% alcohol septal ablation. Interestingly, 80% of myectomy and 80% of alcohol septal ablation are done in centres in the US that do less than 20 cases a year. There was a mortality difference across all tertiles, so they divided them into 3 tertiles. That's a bit of a tautology, isn't it? What they found in that was that basically, regardless of whether you did a very low number, a medium low number, you still did better if you were done in a higher volume centre. Interestingly, in the alcohol septal ablation group, it was really only poor outcomes if you were in the centres that were doing less than 10 cases a year. So interestingly, surgery done by infrequent operators who are doing bad operations is much worse than alcohol septal ablation that is being done infrequently by operators. And this is the data if anyone wants to have a look at it. Certainly there's a significant difference across those groups. So how do we think about things? So the recommendation is that if you have suitable anatomy and pathophysiology, if the distribution of the septal perforator allows alcohol to be delivered into the right spot, if you don't have too thin a septum or don't have too thick a septum, and if you don't have abnormalities in mitral valve apparatus, and the patient is suitable, such as advanced age, not a good candidate for surgery, or the patient doesn't want an operation, which most patients, and there's no other indication, then alcohol septal ablation is a good option. So I'm going to take my little bit of privilege with being one of the moderators of the session to ask your advice on a case. This is a guy who came to see me just before I got on the plane on Thursday. He's a 63-year-old fellow. He's got shortness of breath on minimal exertion, so he's quite symptomatic. He's beta blocked to a heart rate of 50, and he says he feels terrible. He just can't do anything he wants to do. This is his echo. So you see significant SAM there, probably obliterating the whole cavity. Certainly turbulent flow and acceleration. Bit of mitral regurgitation, we could argue how much there is there. This is a bit of a close-up view of it. You can see that certainly a knuckle underneath there and SAM. That's his dimensions, so we've got I guess his septum's about 2 centimetres thick. That's his gradient in the LV outflow tract. It's got a velocity of about 7 metres per second. This heart rate's here is 85, but apparently on an echo done with a heart rate of 50, it's not too different. This is his angiogram. So we're looking at where the septals come off. Those of you who are eagle-eyed may notice, in fact, that his first septal actually comes off his diagonal branch, not off his LAD. see, draw your attention to, that's the diagonal, and you can see the septal actually coming off the diagonal. Okay, so what should we do with this man? Dr. Schaff.
There's a couple of interesting points. The first question, and the guidelines say that patients should have adequate medical therapy, but there's wide latitude in what adequate medical therapy is. Patients on a beta blocker, should he be put on disopyramide? Does he need that? That's not our practice. It is the practice in some centers in the U.S. that you have to go through stepwise in medical treatment, beta blockers, calcium channel blockers. If that doesn't work, disopyramide. But we found that that's not very useful. In a patient like this, I'll tell you what we do, and then I'll tell you why. We would do a transaortic myectomy, and then we would do a transapical myectomy to enlarge the ventricle. When I spoke to you about enlarging the ventricle in patients with apical hypertrophic cardiomyopathy, that's a specific phenotype that everybody can recognize from the back of the room. But there's another group of patients who improve with enlargement of the ventricle, and these are patients whose ventricles collapse during systole. They completely obliterate. And the problem that those patients have is they may have an adequate end-diastolic volume, but when their ejection fraction is so high, they can't augment their cardiac output when they exercise. And one of the most interesting patients that I've had with that was actually a surgeon who described it adequately. He said, I used to be an exercise nut. I exercise regularly, and now every time I exercise, my heart rate goes to 160. Because the only way he can increase his cardiac output is by increasing his heart rate. He already obliterates his ventricle, so he can't increase his end-diastolic volume with exercise and increase his ejection fraction. It's already 85%. And that's what this guy looks like. So because he has that, I would do a transapical myectomy, and because he has SAM, I'd do a subaortic myectomy.
Thank you. So that's what I told the patient when I saw him, and he's scheduled for that on Friday when I get home. So at the moment, the guidelines do provide some direction for us. It says surgical septal myectomy when performed by experienced operators is the first consideration for the majority of eligible patients with HOCM. When surgery is contraindicated, the risk is considered unacceptable because of serious comorbidity, advanced age, alcohol septal ablation provided by experienced centres can be beneficial. Okay. I'd like to finish there, but I just also want to highlight, I guess, the topic I was given was apples and oranges, and clearly this is the case here. These patients, they're all very different. The patients that are suitable for alcohol septal ablation are a small minority of the patients with obstructive cardiomyopathy, whereas with surgical patients is a much broader population. There will almost certainly never be a randomized control study of alcohol septal ablation versus surgery. The number of patients that you would need to screen to find a subset of the population that was suitable for both would be very small. I would encourage you all to have as much understanding of alcohol septal ablation, how it works, who it's suitable for, in order to give your patients the best informed choice. Thank you very much.
Any questions, sir? Thank you, Aubrey.
Excellent. That's what I wanted.
Next presentation will be Dr. Usui from Nagoya University.
I need adapter. Okay. It's okay.
To work?
Okay. It is a very honor to present my paper in this meeting, especially the famous Professor Schaff. And it's an innovative technique to prevent SAM in HOCM surgery. Slide shows the JATS annual report. We did under 70,000 cases in a year, but surgery for the HOCM, and the number is very small, only the 120 myectomy and 10 cases of myotomy. So the number of the surgery is very small. And I show the background. In patients with HOCM, LVOT obstruction can be created by the hypertrophic interventricular septum, as well as SAM. Sufficient septal myectomy is theoretical and fundamental criteria to treat LVOT. However, the reduced SAM is another key aspect. So it's the shaman. And hypertrophic interventricular septum obstruct the LVOT. And also is SAM is another mechanism to obstruct the LVOT. So it's sufficient myectomy is the fundamental theoretical therapy. When it's, I just restrict the movement of the anterior myelin defect by using the floating stitch is another aspect. So it's a procedural concept. Reducing the SAM is a very key way to resolving the LVOT obstruction. And we developed a floating stitch of the anterior mitral defect. And anterior mitral defect is prevented from the touching the interventricular septum and by a floating stitch. And some can theoretically be solved. So we presented this paper on the seminar of the thoracic surgery last year. And this floating stitch is simple. Double-armed Gore-Tex suture, CB4, is applied just on the middle of the tip of A2 and in the figure 8 fashion. And both arms of the suture are fixed to the annuloplasty ring at just the middle of the P2. So the length of the suture is usually determined as the length between the tip of A2 and the middle of the P2, plus 1 or 2 millimeter. With this length, anterior mitral defect never touch to the interventricular septum and can move physiologically. So this is a view of the operation. And also it's a needle stitch technique. I presented this paper in 2013. And in this technique, 3 or 2 21 long needles are inserted in the interventricular septum. And this needle stabilizes the interventricular septum and provides a good exposure of the entire septal hypertrophy. And usually I need this needle for the guard. But is severe hypertrophy in the patient, I retract this needle and to expose the suture line, cutting line. It's a shame. So I present the case. It is a 55-year-old female. And CAT scan shows the severe hypertrophy of the interventricular septum. And TEE also shows severe hypertrophy. Also is a severe SAM. So we applied the oblique incision on the aortic root and expose the interventricular septum via the anterior aortic valve. And just mark to the cutting line. And after that, I put in the needle. I put this needle several times, and I determine the cutting line. And I retract this needle, and I cut the myectomy line. And maybe this is applied to the sufficient reduction of the intravascular hypertrophy. So sometimes it's, in the ventroseptum is not hard, but it's, this needle can stabilize in the ventroseptum. So, and another cut line is I also very free to the anterior mitral leaflet. After then, I inspect the abdominal shoulder or also the abdominal pylori muscle. And I move to the left atrial tomy and export to the mitral valve. And this shows is moderate mitral valve regurgitation. I put in the partial ring. So it's water test shows no MR. And I apply to the floating stitch. And just the tip of the I2, I put in the CV4 suture in the figure 8 fashion. So it's very easy, and it takes only 5 minutes. And both arms are fixed to the partial ring, just the middle of the P2. The length of this suture is important. I usually decide the length just side of the A2 to the posterior ring plus 2 millimeter. But maybe the more longer one is also effective. So this is the final view, and water test shows no MR. So it's intraoperative echocardiography. So it's sufficient myectomy. Also, the anterior mitral leaflet shows a reversed concaved curve and never touched to the intervenous septum. It's no MR and LVOT pressure gradient is 10 millimeter. No sum. It's the so mitral under leaflet just shows that it's a reverse concaved curve and never attached to the septum. And I did the 5 cases. And there are no MR. Also, the LVOT pressure gradient is 9. Also, the posterior leaflet cannot restrict, and maybe the under leaflet restrict. So it's the average mitral valve area is 2.47. So the floating stitch technique is simple and reproachable and durable method to the reducing harm. And it should be considered as the sufficient supplementary procedure with the septal myectomy. Also, this floating technique is can be applied to the sum after the mitral valvoplasty. And this patient shows that it's a severe MR due to the extended posterior mitral leaflet prolapse. So we did the mitral valvoplasty by using the pneumofilter. I put in the 4 pieces of pneumofilter to the posterior leaflet, and but no cut. So maybe the mitral leaflet is very big, but no MR. And after putting the mitral ring, the length of the posterior or leaflet is a little bit high, but it's acceptable. But it's after the moving the heart and the echocardiography shows the severe thumb, also is the moderate severe MRs. So I come up to the second run. So at the time is I do that two things. One is height reduction of the posterior leaflet by using the folding stitch. And also I applied to the folding stitch on the mitral leaflet. In this time I do that two pieces. So this is the folding stitch. I reduce the height, it's about 4 or 5 millimeter. And I put in the 3 stitches. And after then, I do the water test, and it might be okay. And I put in the floating stitch on the tip of the A2. So this is the first time to apply the floating stitch to such kind of the case. So I put in the 2 pieces of the stitches. And one is just a little bit right side, and another one is a little bit left side. So its length is also maybe plus 1 or 2 millimeter. So it's might be the acceptable the water test, and I finished the operation now, and. Unfortunately, after the echocardiography shows no MR and no thumb. And also the anterior mitral leaf shows the reverse concave shape. And also after the operation, I measured the mitral valve area. It's 2.67. It's acceptable. So the floating stitch can be applied for the thumb after the MVP. So for the thumb is several procedures proposed. Might be that the floating stitch can be listed on this holding them. So it's my conclusion. The floating stitch technique is simple and reproducible and a durable method to reducing thumb in surgery for HOCM. It should be considered as a supplemental procedure with a septal myectomy to treat LVOT obstruction. The folding stitch technique can be applied to solve thumb after mitral valvoplasty. And this technique is still in the developing stage, but it is accepted to be a promising one. Thank you very much.
Questions from the floor? I have one while people are thinking. What do you see the advantage of this over the Alfieri upstitch?
Yeah, Alfieri is just restricts both the anterior mitral leaflet and the posterior mitral leaflet. So, and I sometimes use some Alfieri stitch, but some one is broken because it's a stitch on the leaflet tip. And so, and this time I use a Gore-Tex stitch and only put in the tip of A2. Tip of A2 is very hard because it's a thumb. So it's a very good area to fix. And posterior leaflet cannot restrict. And also, anterior mitral leaflet can move. Maybe physiologically. So it's the movement is okay, and also the mitral valve area can be preserved. I think.
Have you done any comparison of the valve area after an Alfieri versus this sort of thing?
I have only few cases of the Alfieri, so it's, I can't compare.
Any other questions? I'm interested, you would do this now for every patient you do a myomectomy on?
No, and you know, it's about sufficient myectomy is key of this operation. But some patients have mild hypertrophy or the moderate hypertrophy of the interventional septum. At the time, this stage is very helpful. So maybe the 40% of the patient I applied this stage.
I just clarify just one thing. In your article, it says stitches go into the ideal direction to the, exclude the outflow septum, that the long needle goes into the, directing to the apex in your article.
Yeah.
But in a real situation, it might be difficult to bring that needle to the ideal direction. Are there any trick for it? Because that you cannot see it. The direction of that long needle.
Put the needle, I just hold this RV outflow. Other time is septum is just compressed. And I can insert the needle, that's right direction. So
it seems very difficult for me to reproduce the direction.
No, it's
the right direction.
We can put in the needle several times, maybe many times. So I put the needle and maybe I tried to several times, and finally I decided to the
you reconfirmed by echo or something, or maybe aortic.
And sometimes we can show that it's the echo, and but the needle is not so heavy one. But it's cardiac echo can show that it's the length, the depth of the needle.
Thank you very much. Thank you. Any questions, comment? Thank you, Dr. Fusui.
Our next speaker is Dr. Asai.
As Professor Usui said, I'm also Raymond. I confess I haven't done more than 30 cases. When I was training in the United States under NYU, Dr. Spencer and Stephen Colvin, I have seen few cases. But I'm very interested in, so I just show my case today. So this is Dr. Andrew Graham Morrow, one of the recent article of Jack. Are there any? And there was article was the first. This is not first article, but there was a good picture. The first article was in almost 60 years ago. IHSS. Oh, I see. A lot of good articles, but in front of Dr. Schaff, I'm not going to talk about too much. So I think key of I want to talk about just a little bit about technical aspect. The trans-aortic approach is, I think, it's a first choice for me, or maybe for many surgeons, to do release of outflow obstruction. And there is in echo, I don't have a good echo today, but there is a lot, always like a snow in Mount Fuji mountain, which is a marker we have to take care of it. In my procedure, and I'm proud of that because very limited experience, I always do not do extensive resection because having more risk of heart block, left bundle branch block. Also, if you go too far, you may create left ventricle, VSD. At the same token, we have some certain anatomy of aorta mitral angle, and anterior mitral leaflet still big enough to cover this smooth, extensive resection. They may still cause some gradient. I think Dr. Morrow was ingenious in terms of leave this dangerous area, but he made just a tract of, let's say, 1 centimeter, 1 centimeter. This special tract would be preserved even though anterior mitral leaflet coming close to the septum, this tract will give you more than adequate space. So I'm not going to cut this too much. That's a point. So I would say the less is more. I'm not going to cut too much. So far, I haven't had any complication of VSD creation, as well as, I think, good gradient so far, no more than 10 millimeter gradient. Also, in some cases, in spite of only moderately thickened outflow septum, the patient having had some redundancy, at least at the middle of A2. In the echocardiogram, you see that coaptation line, if there is more than, let's say, 15 or 20 millimeter of redundancy below the coaptation line, I would not hesitate to cut some redundant part, the leave 7, 8 centimeter, 7, 8 millimeter of A2 region. This can be quite redundant in some cases. In some Western experts putting some plicating stitches or some sort of RP, I don't know what it is, but there's some procedure for that mitral valve from transaortic. But I would just simply cut the redundant tip of the A2. So, and we occasionally, very often, occasionally see this sort of abnormal muscular band. I should say abnormal, or this is commonly seen in the many HOCM patients. So we always identify this and cut this muscular band in addition to the outflow septal myectomy. So that's with abnormal band, okay. I'm sorry, I just, how do I make this video start? Can you click on this? How do you do that? So this is the exposure. So we have some thickening of outflow septum. This may be some component of mid-ventricular obstruction as well. It's not too shallow. However, I so far predominantly use transaortic approach. I open aorta about 1 centimeter distally to the orifice of right coronary artery. And with using small right angular forceps, puts so this blue vessel loop go around the insert of this abnormal muscle here, this goes to the anterior papillary muscle, which is very common anatomy. And I think it's important with this kind of abnormality if patient have. I think surgical resection would be preferred rather than alcohol ablation. It is dangerous to cut. It may injure the mitral valve or aortic valve if you're not experienced. I'm included as a beginner. I myself, it may not recommend it. I put the Arantius body of the right coronary cusp to the aortic wall temporarily to the fibroprotein. I think it's most difficult things in some patients, aortomitral angle or some sigmoid configuration, we need to go deeper. So we have to get a good orientation. I would go at the level of papillary muscle always, and making sure the whitish fibrous thickening will terminate and having a muscular portion. Okay, I have another video, so this is a very thickened, that's abnormal muscular band. And the insert around there's fibrous thickening. So LV outflow tract obstruction could happen even with mildly, as Dr. Usui mentioned. Can you just press this, click on the picture? This is a post-repair SAM, which is entirely different. However, outflow obstruction, can you click this? Again, here somewhere, click. There's many factors to cause SAM after mitral valve. We learn from this. Go next, please. But these anatomical things and these hemodynamic things has to be understood completely. Next, please. Could be managed medically, however. Click again. Okay. Go next, please. So what I'm thinking is this septum to coaptation, C-sept, which is written in a textbook of, I think it's American ACC, the guideline. This length below the coaptation is very, very important, as well as this distance between coaptation to septum. So if you see some coaptation, preoperative T echo, if you have too much redundancy, that you may have to think about how to take care of this. But as contrary to Professor Usui, I would not open left atrium until the patient have extreme rupture coda. I think transaortic approach is most of case, just we can take care of things. 次お願いします。Next, please. So that part is very important. I'll just skip this mitral valve. So we can control the posterior height in some specific case. So this is a case of 59-year-old who have symptomatic SAM with hypertrophic outflow septum. Cardiologist documented more than 80 millimeter mercury of, this is after induction of anesthesia. Some we can see just a little bit tip here, but here is a very narrow coaptation to septum. And septum was 28 millimeter in outflow. So what I do is I put the needle, before going on bypass, we cannulate, very classic fashion. I put a simultaneous pressure monitoring like this. I don't know, it may not be necessary, but that clearly shows left ventricular pressure overshoot compared to the aortic root pressure. So this is the operation. I started with a very low aortotomy. I just take a look at the septum. And here is the right coronary orifice. I learned not to go to the right from this boundary. So I cut with the number 11 bladed knife deeply. This narrow spattle will protect anti-leaflet of mitral valve. This is the thickened area where the mitral valve contacted. With some little compression, we go further, deeper, but not wider. You see the papillary muscle, medial papillary muscle was observed over here. Anterior papillary muscle was here. So this is a chunk of myocardium. It's about 9 to 10 millimeter, not too much. However, we just take a feel and go further. It may be easier, as Dr. Schaff said, if transapical approach to confirm the smooth septum. But in this specific case, I just use predominantly this transaortic case, and some tucking stitches of Arantius body was relieved. That's the most recent case, the last year. So this is about 13 centimeter width, 9 millimeter, and pressure monitoring needle was sticked inside again. After coming off bypass, but not cannula still in before the heparinase. That was pre-op and was completely eliminated. So we were happy to close. And there was no left ventral branch block with these cases. Post-repair echo was, we still have some turbulence here, but clearly this is wider outflow tract, some trivial aortic regurgitation. We could have gone more, maybe, but in some cases, mid-ventricular obstruction, from your lecture, probably I should go from the apex simultaneously in selected cases. So with my limited experience, myotomy is just important, but the part of HOCM surgical strategy, and medical management is also important. We go narrow and deep, adequate, sufficiently deep to relieve. And simultaneous pressure monitoring is, I think it's effective and comforting the beginner like me. And abnormal muscular band or other abnormalities should be checked very meticulously. Thank you very much.
Thank you, Dr. Asai. Any questions from the floor? I guess a comment or a question. I'm very comfortable agreeing with you on the width of the resection higher up. But once you get lower down, surely the
Way
left
wider.
bundle is a long way away. Are you still concerned about the conduction system once you're more than, say, 15 millimeters, 2 centimeters from the aortic valve?
I had a similar question. So I just go outflow to narrow, maybe wider in a deeper area. I think Dr. Schaff knows the right answer for this.
No, I was going to mention, I think you made several very good points. And maybe it's a language thing, but when I'm describing what we do and what we think the problems are with the adequacy of a myectomy, I don't discuss depth, because I think the depth of the resection is the amount you take going up. We like to think of it as the length of the resection. Length towards the apex. And you made that point very carefully and very well, although you called it the depth, but it's a semantic thing. Now, the issue of bundle branch block, where you start your myectomy is very similar to what we do. As I describe it in an operative note, I start the myectomy just to the right of the nadir of the right aortic sinus. Now, we cut up, you go down like Morrow did. I don't think that makes much difference. But we carry it far to the left side. Now, that doesn't have anything to do with a bundle branch block. It's to the right side where you get a bundle branch block. So you can make it as wide as you want to the left. And the advantage in making it wider to the left, in a counterclockwise, is that you have a little better visualization of the length of it, which you showed nicely. So,
Correct me if I'm wrong, Hassel, the limit on the left or anti-clockwise side is really the mitral valve.
it's the mitral valve. You go right up to the anterior leaf of the mitral valve. But, some surgeons, there are surgeons that take it far to the right, but they have a very high incidence of bundle branch block. Now, a left bundle branch block by itself doesn't have any implications for late survival. Complete heart block and need for a pacemaker does. It's just like aortic valve disease. If you look at patients' survival after aortic valve replacement, survival is reduced in patients with pacemakers. And the same thing holds for septal myectomy. So I think you want to avoid the heart block, and we think the best way to do it is to start the incision as you described it.
Thank you.
One comment, I guess. I've noticed that the echo imaging is actually very difficult after myectomy. And certainly you can see that you've got rid of the gradient, you can see that there's no SAM, but looking at the echo to say, this is the space I have, is actually very inaccurate, and you need to be careful to say, I haven't done a proper resection based on just what you see on the echo, because where they're looking, it depends on where they track across the resection that you've done. So we've been using 3D multiplanar reconstruction to try and give us a better idea. I don't know what it means, but we've been looking at that just recently.
Thank you, Dr. Azai. There are a few reports of plication of the AML in these sort of situations. Now, which is a select group of patients which you would electively do your resection? Is it a patient with a long AML, which is shown on a pre-op echo, or?
Well, I can say convincing thing. I did a few times.
Yeah.
Which, interestingly, patient have some floppy type of things, tip of 8 only, like something like, I cannot explain in my English vocabulary, but that is abnormally presented. But we have to be certain, we have a certain length of tissue below the coaptation. Otherwise, we can make, some type 2 mitral regurgitation. But I think this anatomy frequently observed.
That's right.
So I think it's many experts do just a little bit different way, but which is an important component of SAM recurrence, I guess.
It's interesting. Again, I'd be very interested to see what some of the experts in the audience say. My experience with the morphology of the anterior leaflet of the mitral valve in SAM is that it's, in HOCM, is it's very variable. Sometimes you can have a long leaflet, sometimes you can have a relatively short leaflet, sometimes they can be quite scarred, sometimes there's long chords and you see chordal SAM. I'm quite interested to see if anybody has a comment from the audience about their experience of the mitral valve morphology in HOCM.
A question to Dr. Schaff, please. The most common morphology we see is an elongated AML. Is an elongated, in your extensive experience, is it an elongated AML a risk factor for a residual SAM, or should it be plicated electively when it's very elongated?
Well, thank you. It's a great point, and I would encourage you all to attend the AATS meeting this year, because one of our fellows has looked this up and done measurements of the anterior leaflet length and tried to relate that to adequacy of myectomy. We also measured it in patients with aortic stenosis and some other groups. The bottom line is it didn't matter. There are surgeons who plicate the anterior leaflet to shorten it. There's also surgeons that put little patches in there thinking if you increase the anterior leaflet length that you get it out of the outflow tract. I'm right in the middle. I don't do anything to the anterior leaflet.
Thank you.
One more question? Yes.
I'm Dr. Chaibut from Thailand. Regarding to the apical myomectomy, I am worried about how to close ventriculotomy without compromising LV cavity, because I am worried about when we do the myomectomy and then we have to close ventriculotomy with the thick left ventricle. It's quite difficult, or any technique to close the ventriculotomy for apical HOCM. Thank you.
Dr. Sai?
I personally haven't done it, but Dr. Schaff's paper said that the apical ventriculotomy to closure, is it any technical pitfall or problem? Not that much. His question.
Again, while Dr. Schaff's getting up, my experience is it actually closes very well. The apex really doesn't contribute hugely to the contractility in that region. I think the secret is making the incision as close to the apex or well away from the LAD, find where the diagonal branch is and head down there. And again, my experience of closing left ventricles for all sorts of things is they actually close very well. Bleeding from a left ventriculotomy, I mean, touch wood, hasn't been an issue. I'm much more scared about closing right ventricles, to be honest with you.
That's not like post-infarction VSR in acute period. I think it's a more thickened, stable apex, I guess, although I haven't done that. No.
Anything to add to that? Excellent. All right, look, I'd like to thank all the speakers for excellent presentations. Apologies for mine, and thanks for the audience for their participation.